Bismillahirrahmanirrahim. Good morning, everyone. I am Dr. Rahim Maher. The topic for presentation is localized prostate cancer, in which we will discuss about the radical prostatectomy. So before go to our main presentation, the brief review of the TNM classification of the prostate. You can all know that this T1 to T2 is the prostate localized definition. The prostate is localized if it is the up to the T2. So everyone should know about the TNM classification. After classification, this risk group stratification is very important. So always classify your patients when they present to you after all their investigations, radiological and biochemical evaluation. So classify according to in these groups. That will help in treatment planning options. So here I put a scenario: 57-year-old male, no history of prostate cancer, no comorbids, no erectile dysfunction, no incontinence. On DRE, positive nodule was seen. His PSA was 11.5. The biopsies shows 4 out of 12 codes positive. You can see that glycine, not a high-grade glycine in most of the codes. So what is the risk group and what treatment options you offer to the patient? So, and you can answer. Okay. These are the options. "57-year-old male, no family history of prostate cancer, no comorbids, no erectile dysfunction, and no incontinence. On DRE, positive nodule was seen. His PSA was 11.5. Biopsy shows 4 out of 12 codes positive. What is the risk group and treatment options? We go for radical prostatectomy. There are open prostatectomy, in which we can go for retropubic and perennial approach. Number 2, laparoscopic, and number 3, robotic. These are the goals of radical prostatectomy. Number 1, cancer control. Number 2, preservation of urinary control. Number 3, preservation of sexual function, that is impotency. So relevant surgical anatomy we discuss to the RP, venous plexus. The prostatic venous plexus is a network of small veins that surrounds and drains the prostate gland of male pelvis. It communicates with the inferior vesical vein of the urinary bladder superiorly and internal vertebral venous plexus posteriorly. It also receives the deep dorsal vein of the penis as a tributary that drains the venous blood from the deep structure of the penis. The superficial branch and deep branches are in venous plexus. It lies between the puboprostatic ligament. These branches are superficial branches is important because for when we dissect out the puboprostatic ligament, this is the anatomy. This is the puboprostatic ligament, and this is the superficial branch of deep dorsal venous plexus. Can be site of bleeding when dissecting out the puboprostatic ligament. And again, lateral venous plexus, common trach and lateral venous plexus are covered and concealed by prostatic and endopelvic fascia. It communicates with pudendal, obturator, and vesical plexus and form inferior vesical vein. Near puboprostatic ligament, small branches communicate with pelvic side. This slide is very important for everyone. This is the arterial supply of the prostate from internal iliac artery, inferior vesical artery rise. And some then give rise to the urethral group of arteries and artery of the prostate. Some capsular branches receive its arterial supply from the middle hemorrhoidal and pudendal arteries. This is the nerve supply of the prostate. Visceral sympathetic receives from hypogastric, and visceral parasympathetic receives from S2 and S4, and the somatic motor nerve supply. The nerves innervating the prostate travel outside the capsule of the prostate and the non-Weir's fascia until they perforate the capsule where they enter the prostate. The branches to the membranous urethra and corpora cavernosa also travel outside the prostatic capsule in the lateral pelvic fascia dorsolaterally between the prostate and rectum. We will discuss how to save these nerves and how important they are. Striated sphincter, basic anatomy, it's horseshoe shape, it surrounds membranous urethra and smooth muscle. At apex, the edges fuse in midline. The physiology, slow twitch, passive control, active control achieved by levator urethrae and pubo-urethralis. So this is the cross urethral section. This is the smooth muscle surrounded by striated muscle. There is a neurovascular bundle, and this is the prostatic fascia, and this is the levator fascia. Neurovascular bundle lies in between these two fascias, and it's a reverse horseshoe. So these days we call it reverse omega sign. These are the prostatic facial covering. Number 1, Denon-Weir's fascia. Number 2, prostatic fascia just outside the prostate. Denon-Weir's fascia, it covers posterior surface of the prostate and seminal vesicle. It dense at the base, thin at the apex. It must be excised. Prostatic fascia, anterior and lateral in continuity with prostate parenchyma. Anteriorly lies deep dorsal venous plexus and Santorini's plexus. Levator fascia laterally fuses with prostatic fascia, forms lateral pelvic fascia. Neurovascular bundle lies between levator fascia and prostatic fascia. In performing a nerve sparing surgery, prostatic fascia must remain on the prostate. This is again pictorial diagram. This is the superficial branch of dorsal venous plexus. And this is the arterial supply to the bladder neck. And this is the pelvic plexus. Surgery is deferred for 6 to 8 weeks after biopsy and 12 weeks after TURP. It helps to preserve neurovascular bundle and prevents rectal injury. This is for retropubic approach. When we dissect out from midline incision and we go into a radius space and then go laterally pelvic lymph node dissection. It includes the dissection of the iliac and obturator done before prostactomy. Preserve soft tissue over external iliac, inferiorly up to the femoral canal. Obturator nerve passed, preserved. Obturator and hypogastric vessels should be skeletonized. Incision in the endopelvic fascia and division of the puboprostatic ligaments expose the junction between the apex of the prostate and the anterior surface of dorsal venous complex. Pubourethral component of the complex is intact to preserve anterior fixation of the striated sphincter to the pubis. The first step is the ligation of dorsal venous complex. This is achieved with minimal blood loss while avoiding damage to the striated sphincter. See, this is pubic symphysis. Take a suture and ligate them distally. Then figure of 8 suture to make sure good hemostasis. Some people do perichondrium stitches with to get more tightly. And then this is the apex. So take the proximal control dorsal venous plexus. This apex, this is the apex. On this performing stage, we can't find the prostate. And then division of striated sphincter. In attempt to preserve more sphincter, going laterally close to prostate may damage neurovascular bundle. To prevent it, divide sphincter midway between the apex and distal end. It was believed that neurovascular bundle always travel in a straight line laterally, but sometimes accessory vessel may pull it medially and cause injury. This manual overswing of striated urethral sphincter and dorsal vein. This is V shape of suturing of dorsal venous complexes posteriorly. So careful because near the apex. After resection of urethra, first of all, anterior 2/3 of urethra is divided when you see Foley catheter, not to cut whole urethra, just 2 to 3rd anterior urethra, because neurovascular bundle here. After this, when C Foley catheter starts suturing, you take a stay suture from 12 o'clock position in all these locations. After that, clamp placed between posterior striated urethral sphincter and neurovascular bundle. These days, with excellent instruments and knowledge of anatomy, every attempt should be made to preserve neurovascular bundle. In nerve-sparing surgery, prostatic fascia should be saved. After resection of urethra, now this is the prostate.
And another very important point for this neurovascular bundle is when we started performing robotic prostatectomy. So Dr. Badamia came and he used to ask us that on which side of the prostate was that tumor, which lobe was that involving, and we have to go into a lot of detail, and then we have to decide that we have to save this or not. But the main principle always remains that you have to have an oncological control. This neurovascular bundle comes a bit late, because if you are compromising that, then it is of no use. So you have to be very vigilant, and you need to know the anatomy of this. And a bit about dorsal venous complex, that it is one of the biggest fears of urologists performing a prostate surgery. And we have seen when we started and it used to bleed, the patient used to go in a dip, and we have to push the blood and resuscitate the patient and place a pack. And in the initial days, we placed a pack in patient, and then we came back next day or 2 days later to perform the surgery. So this is very important. And one point I would like to add, being an enthusiastic, minimally invasive surgeon, that a lot of people, I have seen videos, when they could not suture it, they used to place hemolog clips over there, and then they used to cut. And in one surgery, I was astonished to see that they placed a GIA stapler. They made some place, and it was a very thick dorsal venous complex. They placed the GIA stapler, and they used that gun, and they ligated that with that. So multiple things can be done, but you have to have good control over these things. If these things bleed, they can be life-threatening.
Oh.
Hello, Haris. Hello.
Yes,
Hello.
sir. Yes, sir. We can hear you, sir.
Can you please tell us what are the conditions where the neurovascular bundle is not necessary to save? In which conditions we should not attempt to save the neurovascular bundle?
Sir, when the prostate has gone locally invasive, it has crossed the capsule of that side, and we have to see, while the biopsy report, we have to see that what was the mapping of that prostate, which side was and which lobe was that involving. So on these things, then we decide that should we preserve it or not. And preemptively, we have to inform the patient that this can be done or this cannot be done, or we can try to save it or not.
I think other thing is that if we can palpate the tumor at the apex of prostate, then there is no point in saving the neurovascular bundle because of good control of cancer. And the other thing, we should avoid using cautery in this area. When we are dissecting the apex and the lateral surface of the prostate, we should avoid the cautery, use of cautery. That can damage the neurovascular bundle.
Yes, sir. Yes, sir. We have seen that when Dr. Badamia used to do it, he used to cut it with a cold scissor. Absolutely right, because that will damage, the he will damage it.
And sir, if the tumor is involving the one lobe of the prostate, then we can sacrifice the neurovascular bundle of that side, and we can preserve the other side, contralateral side, so that at least venous should be preserved next.
Yes, so these are the few conditions where we should not save the neurovascular bundle. One is if the tumor is palpable at the apex, and if the other one lobe is palpable and involving this neurovascular bundle. So I think these are the conditions, and the old age of the patient, where the control of disease is more important than the impotency preservation. So these are the conditions which we should have in mind while saving the neurovascular bundle.
Sir, at times the tactical sensation is also lost, so patient cannot feel as well. What's your take on?
Yes, during the laparoscopy, but during the open surgery, like retroperitoneal, retropubic prostatectomy, open surgery, the tactile this contact may remain intact. You can feel the prostate lateral lobe or the apex. During the open surgery, I was talking about the open surgery use.
Munsab, you are very right, because this is a very burning kind of issue, because earlier and these days also a surgeon has got this kind of say obsession that he wants to have the prostate out and have to have something called nerve sparing surgery, so that his name should be on top of the list, because the patient is not having incontinence probably and not having impotency. But now there are ways and means of doing it pre-operatively in terms of planning. For instance, these days we have got the availability of 3D planning and 3D printing. Now, these are some of the few cases in urology where 3D printing has got its value in the form of having known not only the site of the tumor, but also its depth, whether it is superficially located close to the capsule or whether it is located somewhere deep down. If it is superficially located, either on the right side or left side, maybe at the site of apex or maybe at the site of base, then there is no point in saving the nerves on that side. But if the tumor is quite deep, it is not on to the capsule, then you can save the nerves.
Right.
Because if you just shave off the tumor and shave off the prostate by laparoscopy, open surgery, or robotic, you can leave a bit of a disease with the nerve. And later you have to combine it with maybe 6 months down the line with radiotherapy. And these are the cases which we have seen in one of the places in this city also, the largest series of radical prostatectomy done in one of the hospitals in Karachi. And they have got their patients 6 months and 1 year after prostatectomy going towards radiotherapy. That was because of the reason that the nerves were spared and the disease was there. And the proof of the pudding is the PSA starts rising after your radical prostatectomy.
Yes, I totally agree with you that the first aim should be to have a cancer control, and then to preserve the neurovascular bundle, and then to preserve the continence. The three important objects of surgery are that cancer control should be on the top. You are right. Yes, I agree with you.
After resection of urethra, the prostate is here. When we dissect the neurovascular bundle, for which we incise levator fascia, this is apical branch of neurovascular bundle, and this is how apical branch is clipped and divided. And the non-Mears fascia is dissected, prostate free from rectum, and division of bladder neck, separation of seminal vesicles. And then anterior bladder neck is incised, move it laterally. After this is the seminal vesicle and posterior bladder wall incised. Seminal vesicle and vas D have to cut, taking care of neurovascular bundle. After separation of seminal vesicle and vas D, bladder neck closed in tennis racket fashion. 2 Maxon suture placed 2 centimeter lateral to the bladder neck.
Cosa is inward. everted as well. In the
Ji.
previous picture, that is a very important point. Over here, on the right side, mucosa,
Mucosa
is
is inverted.
Everted.
Suture is tight, forming an anterior hood of tissue over bladder neck. After bladder neck separation, anastomosis can be done. The anastomosis can be continuously or interruptedly, preference on surgeon. These are the complications.
Just a minute, because whatever you have explained is one of the techniques of doing radical prostatectomy. There are many other techniques also, because here you can see most of your dissection and most of your say intervention is anteriorly into the radius space. Now, if you do this kind of maneuver, and that has been done quite a lot for many, many years, then the problem of bleeding, number one, and number two is the problem of continence is always there, because you are, as you have rightly pointed out, that you are actually intervening between the striated muscle of the sphincter, and you are just putting it under control. So rather than not touching it, if you go back posteriorly, and that is known as radius sparing surgery, and this is the kind of surgery that is being proposed these days, particularly for those who are doing as our team on robot, it will be not only easier, but it will be very much safer in terms of complications also, because there will be no bleeding. The wheel of Aphrodite is intact. And what is the wheel of Aphrodite? You haven't explained it. It's a very important structure. The sphincter is intact. Not only that, the dorsal venous plexus is also intact. So the puboprostatic ligament is also not severed. So that is the kind of technique that we have to learn. That is the kind of technique that is the mainstay of this 21st century now on. This technique that you have explained is the technique of historical value.
We usually start our dissection from the bladder neck, and then we go down and dissect the whole prostate posteriorly along with the denudal fascia. But this was the old and classical teaching.
And both things can be done, integrate and retrograde dissection. But the main point is that from where you will cut that, dissect out that bladder and prostate, that is a very important point. In open, you can easily feel it, and you know that over here it is the bladder neck and over here is the prostate. But when you're doing it laparoscopically or robotically, so there are multiple techniques to do that. A few people fill the bladder and they identify, and then they can, because there is no tactile sense, that they push with those arms and see that it is compressible till here is the bladder and now here is the prostate. So multiple maneuvers should be known how to identify that correct line, that where you have to cut. Because if you don't cut properly, then the bladder neck will be wide open, and then you have to repair that as well. And repairing that bladder neck is very important for the continence, and a lot of things, as Dr. Asad has said, that being done on continence. There is a surgeon, Rocco, and he invented Rocco stitch. So you can understand with Urdu Rocco, ke peshab ko roko. So the continence is maintained with that the posterior muscles which you dissect out while doing surgery, either you spare them or either you repair them later. The levator muscles and all, and that also helps in maintaining continence. He has proved it, and in his papers, and also multiple things are being done for continence as well as impotency in robotic and laparoscopic prostatectomy.
So whenever you are in front of anybody who wants to discuss the topic, so whenever you want to discuss a topic, then it has to be wide range. It has to cover all those things which are of historical value, all those procedures, techniques that were being done. But those techniques are very important that are done these days. So it is very important to know how it is being done, because most of the cases of radical prostatectomy is still, they are not done today in the West through open technique. They are done through either laparoscopic or robotic. So in the North American continent, robot has taken away everything in terms of radical prostatectomy, in the context of radical prostatectomy. But yes, in Asia, we have got a dearth of a lot of things, and technology is one of them. But having said that, whenever a student wants to learn, whenever a student wants to open up the textbook, the student has to, and we are all students of science, we have to open up our mind without any prejudice and read whole subject completely, from the very first historical value procedures to the very last, or the procedures that are being done these days. So because these have got their own philosophy behind. Manzoor Saab is here now. For instance, he has got a very strong understanding and background. We always look for him whenever urodynamics is discussed. This sphincter complex, the internal sphincter, is not only one sphincter. It's not a complete sphincter in terms of what circle. It is, as you have said, it is a reverse omega sign kind of a thing. But the next thing is, it is the length of the prostatic urethra and the bladder neck. Now, if the prostate has got, this is my understanding, and this is the understanding maybe of a lot of people. If the prostate has got, and again, prostate has three components, one median lobe and two lateral lobes. So if the predominant enlargement in a cancerous prostate is of the median lobe, and you take out the whole of prostate, then there will be a wider gap at the bladder neck. You got to reconstruct the bladder neck. Otherwise, continence will not be there. It will be an incontinent patient later on. No matter what you do, no matter how many physiotherapy sessions the patient will not come out of it. Manzoor Saab, this complex of understanding physiology of incontinence is very important.
So, some people, they preserve the bladder neck. There's a concept of preservation of bladder neck, and
So we cannot hear you properly, I guess. Sir, can you hear us? Because we cannot hear you.
Okay.
I guess you people are very lucky that somebody is teaching you, and you people can see that as well. When we were doing our residency, so we used to think that what is endopelvic fascia and what is dorsal venous complex, and we used to see the videos and learn, and now you people are lucky that you can see these procedures and learn them. So Dr. Pradeep, I guess you should involve.
बात क्या कर रहे हैं? What we are talking about? Sir कह रहे हैं कि classical teaching है, जो robot अब आजकल आ गया है, and each and everything, endopelvic fascia. So what is the importance of all these things to achieve what? Power है sir. What is the ultimate outcome of radical prostatectomy?
Sir, good cancer control first of all, and a good outcome of surgery के हम उसकी जो cancer control है, disease है वो control है. First of all हमें देखना चाहिए और less complications, और future में इसका जो lifestyle है वो better हो इस surgery से.
So one is the cancer control, and other second is continence, and third is
sexual function.
and how to achieve all these things.
Dr. Manzoor sir, you were telling us something and I guess the connection was lost. So if you can.
Yeah, so I was telling you that there is a concept of bladder neck preservation. Some people, they preserve the bladder neck to have to have a good control on the continence. And one other thing is that reconstruction of bladder neck, जैसे बता रहे थे डॉक्टर के tennis racket fashion में, जो the opening of bladder neck should be in the range of 1 to 1.5 centimeter, like in this diagram. So this is important that the little finger should be allowed to pass after eversion of the margins. The opening of bladder neck should not be more than 1 to 1.5 centimeter. And some surgeons, they preserve the bladder neck. So there's also a concept of preservation of bladder neck, especially open surgery. To preserve the continence. As we were discussing, there are 3 aims of surgery: good cancer control, continence, and impotence, or the erectile function. So there is a concept of preservation of bladder neck as well. I don't know about the robotics.
Yes, sir, the same concept is in robotics as well. And the main, I've been discussing that the main issue lies that you have to cut and dissect out that prostate and bladder neck from a very acute angle. If that angle goes towards the bladder neck opens wide, and then you have to repair it. And we have seen that in simple prostatectomy patients in which we enucleate it and transphysically, and in which if in a few patients mucosa was lost over it and we could not place a mucosa. So, and it was very huge gap and we could not place a bladder neck sutures over there and cut through was done. Those patients we observed had incontinence in simple prostatectomy as well. So then we started performing that bladder neck reconstruction and making that hole a bit small. And so this is important even in simple prostatectomy as well. So bladder neck is very important for controlling the
principles remains the same. Sir,
Haris, can you tell us what about the laparoscopic dissection and what about open surgery dissection? So I think the difference is that in the laparoscopy we dissect from bladder neck to the urethra, and in the open surgery the classical Walsh technique is that we divide the urethra first, membranous part, and then retrograde dissection of the prostate from the urethra to the bladder neck. This is the, I think, difference between the two techniques. So
sir, both the things can be done. Retrograde, antegrade, both things have been done. We have seen 2 professors performing robotic surgery who are mentors. One used to do antegrade dissection from the urethra first, and the other one, Dr. Badar Mia, did the bladder dissection first, and then he used to lift it up and ligate those seminal vesicles and the supply of the prostate as well, the pedicles, and then he used to go towards the dorsal venous complex. So both things can be done. It is about teaching, that who teaches you and what you start following. So both can be safely done if you know the anatomy and if you have the skills. So it can be done easily.
Right.
And a bit about robotic prostatectomy, that this is one of those procedures that anywhere in the world, nobody will doubt that it should be done with a robot or not, because this is the main thing because of which urology and robotic surgery, pelvic surgery got a power and became popular. Because when we are performing an open surgery, it is very difficult to ligate that dorsal venous complex, and at times it is very difficult to anastomose. Uretrovesical anastomose is also very difficult because of that angle over there, and we have to take blind stitches as well. So we have seen open as well, and we have done robotically as well. So things become a bit easy robotically in prostate, and that is why it is a very popular surgery throughout the world.
And I think another difference between the open valve technique and the robotic or the laparoscopic is that in the laparoscopy, you give the continuous sutures for the urethrovesical reanastomosis, and with the classical open, you give the interrupted. Is it right? Interrupted sutures to have a urethrovesical.
Yes, sir. What our teaching has been that while doing robotically, we have seen double needle suture, and it started from 6 o'clock towards 12 o'clock, both sides, right side and then left side on both needles, and then the tie was done at the 12 o'clock. But a few videos I have seen, people who are very skilled, they take interrupted sutures robotically on prostate as well. They just like open, they place those sutures and they cut it and place a hemolog and take the sutures and then they start tying them. So I've seen that as well. But what we have seen with our mentors and teachers, that they have taken continuous sutures.
Continuous suture with laparoscopy and robotic.
Robotic, yes, sir.
But classical teaching is that they should be interrupted urethrovesical anastomosis in Walsh technique of open surgery.
Yes, sir.
Yeah, thank you.
Dr. Asad, I have a question. What is the role of L-shaped instrument that is known as boomerang in the radical prostatectomy?
That is known as boomerang. So boomerang is one of the ancient, say, weapons of Aborigines in Australia, right? So it has got a shape of kind of an L shape, but it is not a proper L. Normally what happens is this is a very narrow space, and a narrow space has to have, you can't just put any needle which is on a needle holder and your wrist which is locking at 60 degrees going through that space. So for that, the needle has to be changed, either a boomerang needle, which is a different kind of a shape, or maybe you can hold the needle in a different way. If you have got the instrument, I can show you how you can do that kind of maneuver. Now, this is something which we all learn. We have been taught by our seniors. Mandur Sahab has taught us, Altaf Sahab has taught us how to make a normal kind of a needle into a boomerang needle. So you can make it by just holding it in a different way. So if I have got the needle holder, I can show you, right? And though that needle holder and the boomerang needle can go just beneath the, say, this fascia and beneath the dorsal venous plexus, taking venous plexus above it and going below it so that you can tie very efficiently.
And these all maneuvers were done because of that angle. When the robotic surgery came, this all finished because the robotic arm is moving at 360 and now 720 degree. So you can easily turn around that. So this thing finished with that. And boomerang is a weapon which was used by the ancient people. They used to hit it for hunting. And that concept was given for that needle. And with open surgery as well, we modify that boomerang. We hold the needle. Usually we hold the needle like this. But you hold it like this and try to take it. That you can easily
it becomes a boomerang.
turn your arm. So that becomes a boomerang. So it can be modified with that.
Okay, thank you. These are the complications: intraoperative hemorrhage, obturator nerve injury, ureteric and rectal, and the extraoperative are bleeding, thromboembolic event, bladder neck contracture, and urinary incontinence and erectile dysfunction. Perennial approach: Hook, Hampton, Young described the first radical perineal prostatectomy for the treatment of cancer in 1905. In 1939, Bell and colleagues modified the procedure, and until the description of the radical retropubic approach by Walsh, the perennial approach offers visualization of the urethral dissection and anastomosis, resulting in excellent urinary continence similar to the results achieved through the laparoscopic approach. It demonstrates the proved long-term cancer control of radical retropubic approach with low morbidity and rapid convalescence. Selection of patients similar to retropubic approach.
Can you say anything about perennial prostatectomy, because we haven't seen anything?
I also haven't seen it, but I have seen some of the videos, and I also know that this robot was once projected as something that can be done abdominally as well as transperineally. So there were experiments, there were surgeries on animal model as well as on cadavers, perennial approach by robot. But the fallacy, the point is radical prostatectomy, taking out the prostate is one part. The second part is you got to have the clearance of lymph nodes. Now that cannot be done when you go through the perineum. So you can take out the prostate, but for sampling of lymph nodes, you got to go into the abdomen. Now that is available, that space is available, at least the access is available if you go peritoneally or maybe transabdominally or extraperitoneally. One point that I want to mention where the robot has got its own value is dissection of lymph nodes. Now, dissection of lymph nodes these days is done under the guidance of indocyanine green. Now, indocyanine green is a substance which is injected prior to surgery, a few minutes prior to surgery. And that has been taken not only by the vessels of the prostate, supplying the prostate, but also draining into the lymph nodes. Now, all those areas where the tumor is, particularly those lymph nodes which are known as sentinel lymph nodes, having the greatest amount of disease burden draining into them, that can be shown, shown in a fluorescent manner, a green color. If you just put off the top light, you can see that green color in the field. So you can dissect your lymph nodes quite efficiently. Pulling out those lymph nodes which are positive for green color, leaving those lymph nodes which are not of green color. So rather than doing something which is extensive lymph adenectomy, that indocyanine green can help you doing a selective kind of lymph node sampling. And that has got a marvelous kind of a value with the robot. So anything who is doing a robot or robotic surgery for prostate, just to take out the prostate, not to think of lymph nodes clearance, I think he is actually undermining his own kind of a wish. The wish is to have complete control of oncology.
And then even we don't do simple prostatectomy with the perennial approach. There are other complications with the perennial approach, like we can damage the sphincter and anal sphincter as well.
After selection of patients similar to retropubic approach with few additional indications like renal transplantation, those with severe inflammation secondary to placement of synthetic mesh for repair of hernia, the morbidly obese who may not to be amenable to radical retropubic approach typically may undergo prostatectomy by the perennial approach. These are the contraindications: severe ankylosis of the hips or spine, and those with unstable artificial hip replacement may not tolerate the exaggerated lithotomy position. Laparoscopic and robotic assisted laparoscopic radical prostatectomy and pelvic lymphadenectomy. Schoeschler and colleagues performed the first successful laparoscopic radical prostatectomy in 1997. Da Vinci quickly became the dominant robotic surgical device in the field of urology by incorporating sophisticated wristed technology at the terminal ends of the robotic instruments. This robotic system offered surgeons the ability to operate, dissect, and suture with the facility of a human. Is the Da Vinci. Nonetheless, robotic-assisted laparoscopic prostatectomy has virtually replaced by laparoscopic prostatectomy in the United States, and overwhelming majority of new surgeons have adopted robotic prostatectomy as their preferred surgical approach for prostate cancer. Advantage of robotic prostatectomy: minimal bleeding, faster return to normal daily activities. It reduced hospital stay significantly, less pain and scarring, lower blood transfusion rates, improved preservation of physical appearance, 3D vision, reduced risk of post-surgery incontinence and impotency.
I think it took robot to 3 decades to explore the prostate as a whole, because when we used to read book they always say that the result of open and the robot or laparoscopic are comparable. There is no difference, and but with time, the robot has gaining its experience and the precision of the dissection. The robot, the outcome has gone up, and it has completely changed with the open surgery. That precision, that experience that robot has got over the time of maybe 3 decades.
Pradeep, Dr. Pradeep,
Yes, sir. Yes, sir.
as we were discussing, there are three objectives of surgery: cancer control, incontinence, and the impotence, right? Three parameters by which we can compare the techniques. So
Yes,
is there any evidence in the literature that robotic surgery or laparoscopic surgery has got a better cancer control or better continence control or better erectile function control? Is there any evidence, any article do you know where there is a clearly shown that robotics have better than
last
the
yes, sir. If you read the literature in the maybe 10-15 years back, that has shown that there is no difference between the robot, laparoscopic, or open surgery, because the open surgery it was done almost at I would say 60 years now. So it was first robotic radical open prostectomy was done in 1900, and the first laparoscopic surgery was done in 1997. So there was almost a whole century difference. We cannot replace the open surgery in one day or one night. So the laparoscopy has taken its time. Then obviously robot has changed with the added its sophistication and the precision in the minimal invasive era. Now the recent literature is showing that the cancer control, the precision of the dissection, that has also added with the sphincter and the sexual, each and everything has been improving over again with every single day. So it has now completely changed with the open radical prostatectomy.
Sir, to my knowledge, there is no evidence in literature yet that one is superior, right? So it's the man behind the machine. What we should stress upon is the fact that we must know the anatomy. If the person who is doing a robotic surgery doesn't know the anatomy, doesn't know the plane in which the person is putting the hands of the robot will not do surgery. It's the surgeon who does the surgery. It's a tool, and a tool should be in the hands of an intelligent person. The person is very important.
So I think the lesser hospital stay, less blood loss, and early to work. These are the three main advantages of robotic or minimal invasive surgery. But
yes, sir, these are. But when you project it, for instance, to 5,000 cases, then these things become very minimal. Even in America, for instance. So if a person is not staying in the hospital, he might be staying in his own house. So there has to be a period, because in this condition, whenever you do a bladder and urethra anastomosis, the person needs at least 2 months to recover from incontinence. So incontinence is always there. You can minimize that period, but you cannot just nullify that period. So still, even the bigger surgeons, the high output surgeons, they still don't say that this is something which is superior.
Yes, this is what I was trying to stress, that these three things, the continence, cancer control, and the impotency, these three things in all the three modalities which we were discussing, I think there's no clear-cut evidence in the literature that there is one technique is superior than others. Still, there's no evidence-based medicine. But there are certainly advantages like minimal bleeding, reduced hospital stay, less pain, and less transfusion, and early to work.
Yes.
But in these three things, as I know, there is no literature article which proves that one technique or minimal energy technique or robotic is better than the open in these three things, especially the which we are discussing. This is what I was trying to say, and take your opinion that is there any difference in these three things in with the laparoscopy or the robotics over open? Thank you for answer.
Thank you, sir.
So case ma'am.
So earlier said this was the case which was put forward and put before the audience. 57-year-old male, no family history of prostate cancer, no comorbids, no erectile dysfunction to start with, and no incontinence. So the person has got a DRE positive nodule, a PSA of 11.5, and 4 out of 12 cores positive. But the percentage of involvement is very minimal. So the questions were, what's the risk group and what is the treatment option? So anybody from the audience can answer. Anybody from Sakhar can answer. Nazish, you can answer.
That Nazish. Again.
So one slide back कर दें sir.
Gigi?
Slide back.
So ये simple सी history है 57-year-old. अगली slide पे चलें. DRE में positive nodule था 11.5 PSA and 4 out of 12 cores positive. But जो आप अगर percentage देखें ना of every core involvement of cancer, it's like 15%, 5%, 5%, 5%. So although this is something which is like 7, 6, 6, 6 Gleason score, but the volume of disease is very, very minimal. And this is very important. Whenever we want to address the issue of Gleason score, we must see each core in terms of percentile. How much is that core involved in by the tumor?
Sir, the patient should be fall in a risk group of intermediate, favorable intermediate risk group. As the PSA is more than 10 to 20 is lie in between the intermediate group. And for that purpose, the DRE have a single nodule, I think. That's
yes.
what I'm saying. But it's
So, what do you think the treatment would be, should be?
Sir, if the patient have no comorbidities, he can give the option of active surveillance.
Yes.
And also if he's curious about having an anxiety of putting the patient putting himself for the active surveillance, we can also give him the option of radical prostatectomy, keeping in mind that the disease का burden जो है वो बहुत ज़्यादा कम है, तो उसके लिए best option फिलहाल के लिए जो हो सकता है वो active surveillance हो सकता है, in my opinion.
Right. So what do you think, Pradeep?
Can you add something?
Age young.
The disease burden is very low. If you can, we can counsel the patient regarding two options: the active surveillance and all three options. And we should counsel him about the active surveillance and surveillance protocol. If he decision to be on an active surveillance protocol, we should offer him active surveillance as this is our priority. And if he wants to put the tumor out, then we should. It's his decision. It is either active surveillance or radiation therapy.
First of all, the decision is actually guided by the group. It is the intermediate group, as you have said.
Yes, sir.
So if it is somebody who is in the intermediate group, so what should be the choice, your choice as a physician, as somebody who is taking care of him?
Sir, either active surveillance or radiation therapy.
Again, this is not a choice between the three. There has to be a very educated guess rather than a wild guess.
The surveillance, definitely.
देखिए, जब भी आप बात करें ना किसी पेशेंट से, first you must convince yourself first if you are convinced as an advocate, then you can convince your patient sometimes, or maybe have a good discussion. Otherwise, there is no discussion. Patient won't select anything out of these three. He will look upon you.
Sir, should I answer?
जी.
असद फुरकान नहीं देना चाह रहा है हमसे.
Sir, as this patient lies in the intermediate risk group, talking about specifically for this patient, I would then choose radical prostatectomy, and after discussion with the patient.
I think this is the correct answer. Since the patient falls in the intermediate group, we should offer active treatment and keep in on the surveillance. Okay, thank you.
Thank you.
Dr. Asad, this age of the patient, is it a decision making factor for the treatment?
So for me, it is not only the age, it is also absence of comorbid. Patient is very active, and plus what I'm more concerned is the volume of disease. The volume of disease is not much. It is something which is rather we can put him on active surveillance. So my decision would be towards active surveillance rather than towards radical prostatectomy. But that thing differs, yes, between person to person. Because I am more concerned about the volume of disease. It's not the volume. The volume is very much minimal. 5% of the tumor, 5% of the prostate covered by the tumor. I think this is rather too early for this person to have something. Right. Thank you, sir. Thank you very much, sir.